Go. Brilliant. Can everybody see that screen?
Yes.
Marvellous. So I'm going to make a start just because of the timings of everything. So apologies for all the epic IT fails on my part. I think it's a picnic problem in chair, not in computer problem. So you're all very, very welcome to this asthma webinar. Essentially, we've got some real expert speakers talking to us today. I do not count myself as one of them. For those of you that don't know me, I'm Kath Monaghan. I'm one of the medical directors in the ICB. And I used to look after patients with severe asthma, but I've moved on a little bit from that. So we've got some real people who are really delivering this type of care and have got real expertise in this talking to us today. So it's a really good opportunity to get an update on the new guidelines, which I think are really quite a radical change from previous guidelines and are very much welcomed in the respiratory world for reasons that we're going to come on to. Just in terms of managing this, there's quite a lot of people on the call. Could I please ask that everybody other than the speakers keep themselves on mute? And if you've got any questions, please put them in the chat box and we will address them as we go along where we can, but there will be an opportunity at the end for people to ask anything more specific that they want. So please make the most of this opportunity. So I know we've got colleagues on the call from Hambleton and Rich. You are very, very, very welcome. The broad brushstrokes of this is around the new national guidance, but I just want people to be aware that there's some NENC specific guidelines that are currently in development that are going to be referenced today. These are draft guidelines. They're open for discussion. Everybody will be able to comment on them because they'll be going out through the NTAG process, so people will be able to comment. But the draft guidelines refer to NENC only, and I know that Hambleton and Rich are looking at this themselves as well. So this is the kind of the broad brushstrokes. Hopefully I won't take 10 minutes and we can get onto the real bones of the discussion, where we're going to hear from Nicola Green, who's an expert in severe asthma up in Northumberland, Joan, who's a pharmacist with a real specialist interest in asthma, and then Neil Meerampal and Claire Adams, who have got real expertise in children and young people's asthma as well. So just to give you an idea of what's going on, as I've said, this refers to NENC. We've set up 2 development groups, one for adult services and one for paediatric services. And we're using the new guidance to kind of share, to develop some NENC-specific guidelines, which will have evidence-based inhaler recommendations on there. There'll be guidance on when to refer to secondary care, which we're hoping people will find useful. We're not expecting these to be approved until summer 2025. And there's been QOF changes to reflect the updated guidance. I would ask other people to speak to them. I'm a secondary care by background and very far from familiar with QOF. So what's the scale of the problem? We will all be very aware of this. Asthma is a huge problem nationally, and it's a massive problem in the North East and North Cumbria. And we know that patients don't always get optimum care. We know there are deaths from asthma that are potentially avoidable. And I guess one of the real hopes from the new guidance as we get them embedded is that we're going to really, really, really start to address that. We know that over-reliance on SABAs at the expense of ICS therapy is associated with an increased risk of death. There's a very, very clear correlation, as these graphs show. And we know from the National Review of Asthma Deaths, published 11 years ago now, which is quite scary, really demonstrates this. There's a very strong correlation between using lots and lots of SABAs or LABAs without inhaled steroids. And I think the new guidance really, really kind of enforces this. There's a real move away from SABA use, and there's a real move into ICS use from very, very early on in the diagnostic process. And this is because we know that overuse of SABAs and LABAs without ICSs is associated with worsening mortality and worsening morbidity, all of which we clearly and obviously want to avoid. But we massively appreciate that this is a real shift in the way that we've been managing asthma. Hence, the start of this webinar is a start of, I guess, a series of education support events that we're going to be launching through the ICB kind of processes to help support people manage this shift. So that's enough of me talking. Over to Joan.
Hello, everybody. Thanks, Kath. As Kath's already said there, that we're referring here to draft North East and North Cumbria guidance that we've put up in some of these slides. And I have to say, since we've written these slides, the guidance has already changed. So it comes with that sort of caveat that we're giving you a flavour of what we think it's going to look like, but it could well and truly change. In the meantime, we sent out a lot of communications referring you to the Primary Care Respiratory Society, because they've produced a really, really useful infographic, which if you haven't seen it, then the web link is there. We'll put the web link into the chat as well. And I think that's really, really useful. From the point of view of timescales, adult asthma guidelines have started to go through medicines governance processes this week and should be out for public consultation. I'm saying reasonably soon as we've had the chance to tweak them. Pediatric ones are going to take a little bit longer just because we're having to do them in 3 age cohorts. So we're saying summertime just because of the length of time that it takes for medicines governance processes across the whole of the region. No discussion around prescribing guidelines would be complete without us having a few little prescribing graphs. So I don't know if we can go down to the next slide, or can I do them? This here, as Kath's already alluded to about excess SABA use, the red line there is where we are as a regional ICB. That's our prescribing rate of SABAs. We're way, way higher than the national average. It has come down, it's moving in the right direction, but we still seem to love SABA prescribing. And the opportunity that we get for anybody aged 12 and above in these new guidelines is to potentially go SABA free for, I wouldn't say everybody, but lots and lots of people. So we're hoping that that's really going to impact on our prescribing data, as we see there. The next little graph of prescribing data we're looking at, this is high dose inhaled corticosteroids. And again, you can see this is the regional level in the red line, and we're going down, but we're still way above the national average. So again, we're moving in the right direction, but we're maybe not moving as fast as we could do. Now, what I would say is the people out there who could potentially be reviewed and their therapy potentially changed, swapped onto a different MART regime, is this the opportunity to really start looking further and deeper in with your respiratory patients there as to who can manage better on the, I'm saying new regimes. We've known about MART for a while. I think AIR's a little bit newer. So I think they're basically the two data sets that we want to share with you. I'm probably now going to, this is the PEACE CRS infographic that we've talked about. And I think with this point, I'll hand over to Nicola and she'll take you through the adult asthma guidance, the draft adult asthma guidance.
Hi, can you hear me okay?
Yep.
Yeah, I'm also freezing because I'm on call at NSEC and I've had to find a tiny wee room and it's about -4 degrees. So yeah, the new guidelines that are out from the asthma one. So if anyone doesn't know me, I'm Nicola Green. I'm one of the respiratory consultants at Northumbria and I'm part of the severe asthma network in the northeast as well. The important thing to say is I actually hope that once we get the information out there and the education out, it might make things easier over the course of time and, you know, get the right people with the right diagnosis and fast track to the right services quickly, but also try and simplify some of the prescribing too. And the first thing is to say that as we know from the NRAD report in 2014, there's still a lot of things that we could do better. And the first thing is to make sure that we get the diagnosis right. And I think we probably all still recognise people that have had a label of asthma for a long time that don't actually have asthma. And then we're giving a lot of these people a lot of toxic treatments without them getting any benefit from it. So the good thing about the combined BTS NICE sign guideline that's come out is actually it's really pragmatic and sensible, and it's a shift away from what we saw a few years ago. It actually is following some very clear, sensible advice. And the first thing is just some easy diagnostic tools to use, but also recognising when it's not simple and straightforward about how we then get that done. So the first thing is about just diagnosing asthma. And this is just kind of this is kind of going to be part of our draft guideline. And I appreciate that all these things take a bit of reading and can be a bit tricky to follow to begin with. But hopefully if we can explain it clearly, you'll understand that there is very clear pathways in order to do it. So the first thing is obviously just to have a history that's compatible with asthma. Now, it just, we don't need to tell any of you guys this. It's very straightforward and sensible with that. But also then to have an investigation, an objective investigation that supports the diagnosis, and some very simple things that could do it. So now, if you have a history that's compatible with it, and you have a blood eosinophil count above the upper limit of the lab reference range, so in our lab it would be 0.3 or 300 microliters of cells per litre, or a FeNO that's above 50, and I appreciate that we might have some questions about that because about access to FeNO as well, then that can give you a confirmed diagnosis of asthma. So that's the first thing. If there isn't that, then what you would want to do is to move forward on to doing some spirometry with reversibility, and then if you see diagnostic criteria of that with airway obstruction reversibility, then again that confirms the diagnosis of asthma. I appreciate there might be some delay being able to get that, so as an alternative you can also look for peak flow variability, and there's some really good tools that are available to do that for looking for amplitude mean change of 20%, and there's a really good link on the PCRS website for a tool from Southampton that you can just plug in the numbers that you do peak flow monitoring with people, and it will calculate the variability for you with the tool. But that is an alternative if you don't have easy access to spirometry and reversibility and FeNO. And as a last sort of option, if we still don't have a confirmed diagnosis of asthma, that's when we should be doing bronchial challenge testing. And that's not something that we're obviously asking you in primary care to do because it's not available to those resources. So these are people where there's diagnostic challenge where we would be expecting them to be referred forward to us to get bronchial challenge testing performed, and that's another barrier that we'll need to get through because that will have real resource implications for us. And if we still don't have a confirmed diagnosis of asthma at that point, then we should be really questioning, does this person have asthma altogether? So dead straightforward, asthma history. If you then can say that you have blood eosinophils above lab reference range incompatible with a history with asthma, the person has asthma. Or if you have availability to FeNO and their FeNO is above 50, they have a diagnosis of asthma. If you can't get that, if you don't meet that criteria, if you can then get spirometry with reversibility, diagnosis of asthma. If that is not currently available to you, you can, as a stopgap, do peak flow variability and mean amplitude change. Again, it's not quite such a good tool as spirometry, but it's there and it does have a role. If that still doesn't confirm the diagnosis, bronchial challenge testing, and that's something that will happen in secondary care. Does that make sense to people so far? That's the sort of flow diagram that's lifted straight from NICE, but more or less, but just made a bit easier to read. But then probably moving on to more what you want to see day in and day out. Well, what does that mean in terms of our actual prescription change? So this is something that we have put together as our draft guideline about how it might look. And the important thing is, I think, to try and make it as easy as possible to follow with as few inhalers as possible, but looking at the different parameters of how you're going to prescribe it and moving as a sea change away from people being on fixed dose ICSs or fixed dose ICS LABAs with SABA, and instead moving to just having one inhaler that does both jobs. And that will either be air, so anti-inflammatory reliever, that you prescribe people as the first choice one to use as a required inhaler without any SABA, or it will be moving then on to MART after that, where they use it as both their preventer and reliever inhaler. And we've recognised that people have been using MART for some time, but it's not often the first choice. But this is where we should be going as the first choice. So we have narrowed this down to just 4 inhaler choices, and we've put the very prescribed doses and to try and remove that, make it as simple as possible. So I might just give you an opportunity to take some time to look at that and see what your thoughts are on it. And embedded into this is also going to be some links so you can link straight to a website, the Right Care website, that if you click on the inhaler that's there, it will automatically take you to a video to show how to use it as well. And again, it's a stepwise process about where you go. If you then get to where you're on moderate dose MART, where you still have uncontrolled disease, then that's again where the point where we should be questioning, is there something else that needs to be done, and getting people fast tracked through to the right services. So the people who have raised eosinophils or raised phenols, these are absolutely people that we want to see in secondary care, because they will have options about other treatments that are available with asthma biologics. So we want to get people moved onto them as quickly as possible for the ones that are appropriate. If they don't have that, then there's another step where you still have a role to try either Montelukast or LAMAs, Spiriva, or other options that we're going to say are available. And again, these should be for trial periods, one after another, and stopped if they're not helpful. And then at that point, refer on to secondary care. at the same time with some clear recognition about the fact that we should still be doing all the simple things and managing all the treatable traits that can help with improved asthma care as well, such as adherence, which we know is very important, smoking cessation, any other sort of modifiable risk factors that are available, and making sure that all people have asthma self-management plans and annual asthma reviews. So that's going to be the mainstay of things. People have real concerns, I think, over the fact that does this mean people are going to get more steroids in the system in terms of inhaled steroids? Actually, all the evidence base from air therapy and MART therapy would suggest that isn't the case, and that people are not getting toxic doses, and actually your overall asthma control is better because you're getting people on a regime where they are just getting that flexibility of the increased dose of inhaled steroids when they need it, and getting more, and also not having the same adherence problems that you probably have before. So that the evidence does not suggest that's the case. Sorry, was someone going to say something there? No. But I appreciate that's something that people may have concerns about, and something that we can have a conversation about at the end of this. So that's kind of what's going to be the mainstay of the new regime, and again, something we can talk about at the end about what people's thoughts are about that. Is it simple to follow? Is there anything else that we need to have a think about? So probably what's more concerning is that's just that table blown up in a bit of a larger form. One thing people ask us maybe about is what is uncontrolled asthma. So it's anything where it's going to be impacting their lifestyle factors. Anyone who's having frequent regular symptoms, and what we have sort of as a group decided that would be greater than one-time nighttime wakening per week, or persistent use of reliever therapy. So if they're on just the as required anti-inflammatory reliever, greater than 7 doses per week, or if they're on MART, greater than 3 days per week that they're using it. Probably what people are more concerned about is, well, if you're on a fixed regime already with a SABA and a fixed dose of either ICS or ICS-LABA, how do we then move over to things? Now, we're not suggesting a sea change of people who are well established and who are well controlled to move. That we are suggesting that everyone that starts should be starting on the new regime. But if you already have been well-controlled asthma for many years, it's not causing any problems, we are not saying that people need to move over. But for those people who have uncontrolled disease, what we have tried to put together is a simple timetable about how you would do that and how you would move over to the new regimes. And this kind of the mainstay, again, focusing on just a small number of inhalers that we use commonly in practice, and some clear sort of guidance about how to do it. So again, I'll probably just give you a moment just to have a look at that and the draft that we've put together of this.
I think we're a slide behind you, Nicola.
Oh, sorry.
No, it's okay. Who's controlling the slides?
Sorry, it's me. I'm trying to keep up, and I'm trying to look at the questions as well. Are we on the right slide now?
No,
I can see the right slide.
This is changing inhaled therapy in uncontrolled disease.
Yeah. So
it's
this
frozen
is a kind of,
for me, sorry.
Can you see that one?
Sorry, it's frozen for me. Sorry. Ignore me then.
So this is a kind of draft about how we would see people changing over, and hopefully again trying to, I mean, none of these things are absolutely, all these things will require a little bit of getting used to it, a little bit of reading and familiarising with it, but we're trying to keep it as simple as possible, because we appreciate that, it is a lot to undertake, and there is a lot of confusing information out there. So hopefully this stratifies it a bit easier. And I think probably what's more important is for us to have some time at the end to talk through these and answer people's specific questions, and we can go back to these tables, and any concerns that people have, we can sort of address them and try and talk through the problems that you might think they have, or anything that we haven't thought about, or anything that might be more complicated. So I'd rather just spend some time at the end taking questions and talking through it.
I wonder if we do that now then, before we move on to the paediatric one, if that's okay with everybody. So Nicola, there's quite a few questions in the chat box, and they're all around eosinophils. Do you need just one eosinophil reading raised? And there's a couple of people have asked for clarity about the recommendation. You don't need pheno if you've got raised eosinophils. Is that correct?
No, it's or. It's and or. Will we go back to that first slide? I'll just So it's or. So if you have raised eosinophils, now on the BTS NICE, they didn't specifically set a timetable for raised eosinophils. What I would say is I would form what I do as my common practice. So if I'm looking at someone in clinic, I'm looking over an eosinophil trail of as long as I possibly can. So if I have someone who has a history compatible with asthma, and I haven't been able, and there's an eosinophil that's 2 years down the line, but everything else is compatible, well, I would take that as yes. So, I mean, if I'm saying that I would do it in my practice, I would say yes, it should be the same everywhere else. I mean, an ideal one is getting a contemporary one that's up to date, because that would help shape practice for going forward. So I think it's in my interpretation of this, and I hope everyone else that's been involved with this agrees with me, is I would be happy to have any eosinophil within the last 5 years or so. But I would also ask if they could probably get an up-to-date one organised so that you've got a contemporary one as well. But even if that's less than that, if you already have a historical one, it would be helpful. But the reason why asking for that is it could help shape practice going forward, because having an up-to-date one within the previous 12 months can open opportunities of other treatments towards people if they accelerate through the pathway quite quickly, and having them as recent as possible would be helpful. Does that answer that question?
I think so. I can't see any hands up. Does everybody feel that that's answered the question? I can't see any hands and I can't see anything else. Oh, Louise.
Oh, there's one.
Louise Hensel. Lynn Swinney.
Yeah, I can see some hands.
I can see hands, but they're not speaking.
They're not answering. Yeah.
Gillian Elder.
Yeah, I'm fine, thank you. That's fine.
You're happy? Is there anybody that's got any further questions currently for Nicole before we move on? Claire?
I just saw another question in the chat earlier about when to progress to MART from air, and I think we might have covered that in the slide, but was that answered for the person who asked that? So it was when to go from air to MART, and we'd said if they're using air more than 7 doses.
Yeah, so that would be the definition of uncontrolled disease, which is in the guideline, and the definition of uncontrolled disease will be in the guideline that comes out, so you've got that as an easy reference tool. The other thing that's important is that there is still some clinical discretion that can be used. So, for instance, in my practice, when I see people, it's incredibly vanishingly rarely that I will be starting them on air, because by the time they've made it to me, they will already have either have escalated through things and been seen by people, or I've seen them because they've had a hospital admission. So therefore, again, if you see someone and you recognise that they've had, a severity that would be appropriate for them to start on a background regime, then it is okay, it's justifiable for those reasons to do that. If you recognise a reason why you would not be starting at air because they've had a hospital attendances or hospital admissions, then it's totally appropriate to start them on a low dose MART regime as well. But for the vast majority that people you'll be seeing in primary care, air will be the starting point.
So there's a couple more questions. Does ICS have to be stopped before pheno? And if you've got raised eosinophils, do you still need to do spirometry to confirm? I think the answer to the latter is no. The ICS have to be stopped before pheno. What's your view, Nicole?
No, it doesn't have to be. You have to recognise that you might have a suppressed pheno because you're on some ICS already. But again, if you saw somebody in primary care practice and you had if you went back to the first slide, if you had somebody who had a history compatible with having asthma and you've got a historical eosinophil count, that is already enough information to make the diagnosis. It is always still helpful to get spirometry and pheno because it's giving you some baseline starting parameters about where you are, and if the pheno is still elevated despite being on ICS, it's probably suggestive of it's a suggestive and inflammatory phenotype of asthma, which may need some further treatment further down the line, and might be someone where there is more escalation of treatment further down the line. So no, being on ICS may suppress people's baseline pheno, but again, that might just be because they've got controlled disease as well. Important to remember that pheno can be suppressed in smokers, so your pheno may be lower if you're a smoker as well, and pheno can be up in other conditions as well. So it's about putting all the things together: clinical history compatible with asthma and not something else, raised eosinophils and/or raised pheno.
Okay, there's another question. More than 7 doses of air a week? Question regularly. Question what is regularly?
Regularly would be moving to the low dose MART regime. So that would be that you then escalated to having a low dose MART regime. So you have a maintenance daily dose of ICS LABA plus reliever doses.
Claire, do you want to come in there? You're on mute.
Sorry, just to say that QOF is changing to reflect the new updated guidance. I've put the link in the chat to those changes. So they're only looking for one objective test to confirm diagnosis, where currently, you're quite right, it does say Spiro plus one of the tests, but yes, it is changing. Thank you.
So you will no longer need Spiro and Pheno for QOF?
Just one objective test, and that might be a blood eosinophil.
Yeah. So
Yeah.
just to be very clear what I think we're saying, because there seems to be lots of questions about this in the chat box. If you've got history in keeping with asthma and you've got historically or currently raised eosinophils, then you can make a diagnosis of asthma.
Yeah, and I think it's very key that you make sure you're confident about your clinical history compatible with that as well.
Yeah. Okay. So another question's come in from Katie. My question is, how many doses a week counts as regularly? 1 week someone might need a bit more, but then things settle.
So I think we've probably covered that with the air and what we would term as uncontrolled disease. So it would be using it persistent use. So, I mean, like you say, if, for instance, the winter we've just all been through with RSV and flu. So if you had, you know, a viral infection and that for that week or those 2 weeks, you used it 7 times, but every other week of the year, you'd use it twice or once. It's persistent use. How many weeks is persistent use? Well, I think probably we haven't, that's a good point. We haven't put a number to that. I'm kind of reluctant to put a number to that because then people we absolutely stick to it. But I would say if you're having, you know, more than 2 or 3 weeks in a row where you are starting to use it more than 7 times a week, that is persistent use.
Fabulous. There are still some hands up. Are there any more questions that people actively want to ask?
Thought maybe there might be some questions about switching people, because this is about if you've got someone who's already on an established regime and you think they are not well controlled and you want to switch them. So I don't know if I would just put that slide back up in case that brings on any questions.
Say stop when we get to that one. Where's it gone? Is it this one? Changing inhaled therapy in uncontrolled disease.
Yeah.
Yeah. Louise, Lynn and Gillian, you've got your hands up. Is there any questions that you would like to ask? Or are your hands up by mistake?
Sorry, mine's up by accident. I apologise.
It's okay, don't worry. I just don't want anybody to miss out on opportunities. Louise and Lynn, are your hands up by mistake or have you got questions you want to ask? Okay, no reply, so I'll assume nothing. Are there any other questions that anybody would like to ask Nicola? I don't know why I keep calling you Nicole. Nicola, before we move on to paediatrics. Victoria Bright thought Symbicort was only Symbicort was licensed for air.
Yes, you're right. Currently it is, but however, Chiesi is seeking a license for air, for Fostair. It's going for a global license for it, and that will come. And there is very clear instructions from BTS NICE sign that we should be allowing off-label use of things, including for air therapy and for individuals. So it is very much supported by national bodies, and it's supported by us regionally to do this, and it will come, but these things will take time. So I know for a fact Chiesi are definitely going for a global license for it, and I suspect Durarest will as well. But yeah, you're right, at the moment they don't have licenses for air, but we are as a region supporting it, and nationally it is being supported to use it like this.
Thank you. And there's a question about, does being on air or MART affect eosinophils?
So remember, being on air or MART, you will start this because you are making the diagnosis of asthma. So you will already have that positive eosinophil count or Pheno to make the diagnosis in the first place. And yes, it might improve it, but for the right reasons, because you've got better controlled disease. So and equally, you know, it's something again that I would look at over the course of time when I see patients. So it might suppress your eosinophil count, but that's potentially because it's controlling your disease. If it's not, if your eosinophil count remains unsuppressed and elevated, and you're seeing somebody and you're recognising that because they've got uncontrolled disease, it will be again clue you into the fact that there needs to be escalation in their therapy, and again may also then subsequently point them down the track about more rapid transit towards secondary care because of access to other treatments because of that phenotype of disease, specifically asthma biologics.
Thank you. A couple more questions and then we are going to move on to paediatrics. If we need an all 12 puffs, what guidance is there for exacerbations for the management plan?
So again, that would be if we think about uncontrolled disease, and can you go back to the slide that has the flow chart about referring on to secondary care? So if you are on moderate dose MART and you have uncontrolled disease, so by our definition, that would be using your reliever more than 3 times a week, then that if you are using 12 puffs every day, then you have uncontrolled disease and you should then be getting other assessments done. We should be trying to manage all their other treatable traits. If they have any other modifiable factors like elevated eosinophils or elevated FeNO, they should be rapidly getting referred through to secondary care, because these are absolutely people who can benefit from asthma biologics, and we should be trying to see them as early as possible. And if they do not have those factors, then there are other opportunities, things to try, Montelukast or LAMA, and in stage processes. For trial periods, stopping them if they're not effective is the other important thing always to say. And if they are still exacerbating despite that and using it, then we very much would want them to again be referred forward, because the question is, why are they still exacerbating so much? Is there anything, what else needs to be done about it? Are we still confident we've got the diagnosis? You know, you have to still be, are you confident the diagnosis is right?
Thank you. And then we've got Tracy Thompson's hands up.
Hi. Is there still a role for Trimble inhaler? Because we have got some patients on it who aren't keen to come off and go under a MART therapy.
Yeah, and I think if they're well established and they're doing well, we are not advocating for changing in them. So people who are on treatment, who have historically been on treatment and having good control, we're not saying you need to change those people. It's about new changes. Now, Trimble will still have some knowns. What I'm not keen to do is to have it in the guideline as an option, because that is people on high dose. Well, there is moderate dose Trimble as well, moderate or high dose, but as a fixed regime. So again, it's something which I don't want it to be. I don't think having it in the routine guideline is necessarily helpful, because it's probably adding another level of confusion back in about the fact we're offering a second option of something, whereas that's not the route that we're advocating for people as new starters. So the route that we're advocating, and which is very much the national edict now, is we should be going with MART therapy where we can. So yes, there will be some people who are already previously established, and if they're doing well, they do not need to change. And there will be a limited role for it in other patients. Though it's still always the right device for the right patient. And if there is somebody who you can recognise for specific reasons are much better on fixed regimes, then for people who have I think this is where it's really important that it's people who have an understanding of an education in asthma that do it, because I don't want that to be the default position. And I think that's where we're moving away from. So if it's people who have confidence in managing it, that and the right reasons for doing it, and they feel that there's a really justifiable reason to do it, might be for an adherence reason, might be for ease of access, it might be for that somebody that really struggles with adherence without having it in a single device inhaler for everything. Then I think it can be justified, but it shouldn't be the routine default position in the guideline.
Okay, thank you.
Thank you. One final question, Nicola, if that's all right, and then we'll move on to paediatrics. Is there a flow chart on the time frame of stepping back down on treatment?
There's sort of advice, there's sort of vague, there's sort of kind of loose advice. What I would say is that's kind of where, this is why MART might come into its own, to be honest, because it allows you that flexibility of stepping up and stepping down treatment without there having to be, if people are well enough educated in the first place, without it having to be something that's really directed from a nursing or physician to do it, because you will have that flexibility and the variability of symptoms, where they will be taking extra doses when they have symptoms and less doses when they have no symptoms. What I would always say is that's the whole point of an annual asthma review as well, is we should be establishing whether or not we can either step up or step down treatment. So that is something that should be addressed in your annual asthma review. And people should be getting seen sooner if there is deteriorations in their control as well. So we shouldn't just be doing annual reviews in people who are exacerbating. So it's something that should definitely be addressed at an annual review, and it's something which will be easier addressed and be done by sort of accidental default with MART, to be honest, because that's how it works, that when they are well, they will be taking less doses. When they are not so well, they will be taking more doses. I saw just in the question about the asthma action plan. I think the asthma and lung UK one is a really good version of all of them for both MART and AIR.
Thank you so much, Nicola. That's been really, really, really helpful. I'm going to move us on now to the children and young people. So I think we've got Neil Minnie first of all. Neil Minnie, do you just want to tell me when you want me to move the slides on? So I'm not
Yes,
creating havoc
yeah.
with the wrong slide at the wrong time.
Thank you. Hi, I'm Nilmani Rampal. I'm a consultant pediatrician at the QE, and I also work with the Child Health and Wellbeing Network as clinical lead for asthma. To say that also we work very closely with the Beat Asthma team, and we very much promote their resources and the resources from Healthier Together. So there's lots of information in relation to pediatrics on both websites. Next slide, please. So I think I'll try and keep this very brief so that we finish in time. And with pediatrics, obviously, there's a range of age groups that we are dealing with. And we will try and go through what the guidance is for under 5s, and then 5 to 11, and then 12 and over. With the under 5s, the major challenge is that they can't really do objective testing, so we struggle with that, but also that very much their symptoms are often driven by viruses, and many of these will not necessarily be asthmatics, but will be children who have what is often termed viral induced wheeze, or has lots of different names, but very much symptoms that are triggered by viruses. So what the guidance is saying is that we give them a trial of inhaled corticosteroids, and then we review them, and if they are better, then we take that off and see whether the symptoms recur. If the symptoms recur, then we put them back on and then review them again within a year. And if things are not getting better, then we consider adding Montelukast. What is obviously very important to highlight when we are adding Montelukast is the fact that it can have side effects. And increasingly, we do see people who report that it has an effect on their children's behavior or their sleep. So my personal experience of Montelukast is for children in whom it works well. It works really well, but it doesn't work for everyone. And therefore, it is very important that we review and stop it, because the side effects can be troublesome. And again, we also now see people who do report neuropsychiatric effects. And again, there's been a lot of communication recently to say that we need to highlight those side effects. Next slide, please. So this is the kind of draft guidance that my previous speakers have also referred to, that we are working along. It's very much what's recommended in NICE, and has been just adapted with some more information in terms of what inhalers to use. But again, we would try and keep it simple and signpost you to either Clenil, to Clenil and to Salamol, just because Salamol is much more environmental friendly. As Claire has mentioned, and I think Kath has mentioned as well, a lot of these are still in draft, so we're still working on them, and there will be the final version eventually that will be circulated. So this is very much what I have spoken about just now, but also just to signpost you to the little square right at the end on the left side that says Healthier Together Primary Care Referral Pathway. Is if you click on that, it will take you to the to the referral pathway that's been developed by the Child Health and Wellbeing Network, very much by my colleague Dr. Hegab in South Tees, and that gives you a checklist of what you can do in primary care before referring them, but also recently that pathway has now been digitalized, so you can just tick it and send it as a referral. Next slide, please. So with children, the main change in the guidance is very much the focus on objective testing. And like everybody else has said, is, you know, the objective test would be used in conjunction with a history that is suggestive of asthma, whilst in theory, it's easy, you know, it's very helpful, obviously, to have the objective test. In practice, we know that there is difficulty with access. It's not easy to access spirometry and FeNO widely currently in the region. And again, there's a lot of work going in relation to that. Secondly, the difficulties that not all children are able to do it, even if the guideline says at 5. A lot of the time at 5 they can't always reproducibly do the test. So in our experience, again, sometimes they will manage it when they're a bit older, about 7 or 8 sometimes even. So we should try and get some objective tests. For the pediatric population, FeNO is the one that they recommend first, followed by bronchodilator reversibility. And like I say, access is not necessarily easy with these tests. So one of the things that can be used and can be used widely in primary care is peak flow variability. And failing that, then skin prick tests and blood eosinophil, again, as been discussed before. Again, access to that might not be that easy. And in skin prick testing, what they're looking at mostly sensitization to house dust mite. Next slide, please. So for the children who are between 5 and 11, at the moment, the guidance is to continue on the kind of conventional pathway that we've had before with the ICS and SABA. If they are not better on that, then we would assess whether they have the ability to use MART or not. MART is not licensed in that age group currently, and therefore it is an off-label use. But again, many of us will have already been using it before the guidelines came out. Again, we would say that we see that often children do get better on it. And in this age group, I think sometimes it's difficult to know whether they've got better because they've gone on MART or whether they've got better because they're actually using an inhaler that is easier to carry and easier for them to have in their pocket. Because a lot of the time when we see them in clinic, the older children certainly will admit that they don't use the inhalers via their spacer. And obviously, if you're using an MDI, then it is absolutely crucial that they use their spacer, because even with the best of techniques, it is unlikely that they will get enough medication. They'll probably get less than 20% of their medication if they're using an MDI without a spacer. It is worth saying that, again, choice is extremely important for everyone, but particularly in the pediatric population. Whilst they may be at an age where we think in theory they can use a dry powder inhaler, many of them will not manage, and they have to use an inhaler that is the right inhaler for them and that's going to deliver the medication for them. Next slide, please. So again, that's the same guidance that's been lifted for our draft guidance that we are doing, and it will give you some guidance in terms of which inhalers to use. Currently, the only inhaler that is licensed for MART for older children is Symbicort, and a lot of the evidence is very much on dry powder inhaler and Symbicort. In terms of ICS with Elaba, the one that we tend to use would be Combisal, which is the equivalent of Seretide, and Combisal is just a cheaper version of Seretide, so that's the one that we would encourage people to prescribe. The guidance will say that if they are not better on an ICS and not able to manage MART, then to go to, again, try Montelukast and then try an ICS with Elaba. In practice, I would say that the history is extremely important for, again, my own personal experience is that if exercise is very much a trigger for them, then often adding Elaba is what makes the difference. Next slide, please. This, again, is taken completely from the NICE guidance, and we won't go through this in detail today, but essentially it just reiterates what everybody else has said about the general view that we should move those who are able to be on MART, partly because of the clinical benefit and also because it is environmentally much more friendly. I would say that whilst the guidance says about LAMA, I wouldn't expect people to use that in primary care, and even in secondary care, we often don't use it very commonly. And a lot of children who will end up on these types of medication will often end up with tertiary care. So what we would expect that you are able to initiate in primary care would be ICS, would be low dose MART, moderate dose MART, and then we would expect that those children would be referred to secondary care. The main message from all of this is that, again, as been already alluded to, is that we want to move away from using just salbutamol or Isaba or Salamol, because we know that this is associated with more deaths, because simply it doesn't control the disease. Next slide, please. So again, this is taken directly from the NICE guidance. And for us in pediatrics, AIR will be a new kind of concept, because we were not using that in children. We were using MART, but not so much AIR. And at the moment, that's the recommendation for children age 12 and over. And if they still continue to be symptomatic, then we would move them to low dose MART. And as we've said, there are very few options when it comes to MART in children. Next slide, please. So the MART plans are available on the Beat Asthma website. Those are the ones that we tend to use and promote regionally. And normally we would give one for them to use at home and one to keep in school. Next slide, please. So in terms of when to refer to secondary care, this is on the primary care referral pathway that I was referring to earlier. But if the asthma symptoms are not controlled, and by that we would mean if they're having symptoms most days for more than 3 months, if they've had 2 or more courses of oral steroids, they've been seen in hospital, they're collecting more than 6 SABAs a year, although we would say to them that what we are aiming for really is less than 3 SABAs per year would indicate good control, but just in terms of capacity and being able to pick up the agreement was that it would be 6. It's difficult again in pediatrics if you're looking at how many prescriptions are being collected, because sometimes people will request more than one inhaler because they may be in more than one household, or they may be requesting one for school. So just looking at how many inhalers they've collected is sometimes again more difficult to give you a direct view as whether it is because of control or because they're collecting multiple inhalers for multiple settings. If they've got an asthma control test of less than 20, but if there are any other kind of vulnerabilities, such as psychosocial issues or safeguarding effect, concerns, or we're concerned about neglect, then the threshold to refer them would be much lower. And equally, if the diagnosis is unclear, then again, we would want to see them in secondary care. Next slide, please. We do know that in the region there is a bit of difficulty at the moment, because we know that a lot of children do not get their annual review, and it's not necessarily because they're not being offered, but often it is because they're not being brought to these reviews. It's quite a difficult area that Claire has done, I think, is doing quite a bit of work on, because we don't quite know whether they're not being brought because the symptoms are well controlled, or because there is an element of neglect. So at the moment, my understanding is that they get 2 invitations, and if they are not brought, then they get taken off. So again, there's been some work that's ongoing at the moment to try and see how we can do that better, so that we are not missing out on the ones who are uncontrolled and are not being brought because there's an element of neglect. So where you feel that there is a safeguarding element, then again, I would say have a low threshold to think about that. Next slide, please. So for the pediatric population, I think the guidance is quite a shift in terms of how we treat. There is more emphasis on objective testing. There are challenges with accessing objective tests, as we've discussed. I would say in practice, probably we will be looking at using peak flow variability more, because that's just more easily done. There's very much a shift to MART in older children wherever possible, and AIR is a new concept for us. And there is quite a challenge, I think, for us to be able to embed the guidelines in schools, because at the moment, what schools have access to is a SABA, and they're allowed to purchase that and keep that in school, but they won't be allowed to purchase Symbicort, for example. But we very much want to drive the message that a SABA should not be prescribed on its own, and we would be very much wanting to move away from SABA use. And either they should be on a SABA in an ICS, or they should be on an AIR regime or MART. Thank you.
Thanks, Neil Monique. So as you've heard from the speakers, and I think we've stated a couple of times in the slides, regional guidelines are expected in summer. We're actively working on those, and that's one of the main reasons why we're not at liberty to share the slides really, but I have put a link in the chat for the PCRS because they ran a really useful webinar a couple of months ago, and they actually have their slides set on that website as well, so it might be useful for you to look at those slides because they are absolutely reflective of the national guidance, which of course our regional guidance is. And I know the Yorkshire teams are working on those as we speak as well, for those of us joining, those teams joining from Yorkshire. We've given you the link to the PCRS infographic as well. Again, think about which patients. I think both speakers have highlighted that beautifully in terms of, don't delay referral if you've got concerns in terms of control. And just to kind of follow up very briefly before we go into questions on Naomi's point, in primary care land, we send 2 letters to patients, and we in the North East North Cumbria had 8,000 children who hadn't been brought for an asthma review within the past 18 months. And that's a kind of a central process QOF issue, which Jen Townsend, our national CYP lead, is kind of addressing centrally. But I'd just ask you to think in your practice, have you got a process for kind of not letting these children slip through the net, so to speak? And, have you got an element of follow-up for these children who might be falling by the wayside? So just going to the next slide, which takes us back to Kath, and thanks for your attention.
Brilliant. Thank you so much. So I've been trying to keep an eye on the chat. I think there's a couple of questions that I don't think we've definitely answered. Is there education going on in schools to ensure patients have got access to their inhalers?
Yeah, so there is quite a lot of work going on with schools in different settings, and via the network there is a scheme for schools to become beat asthma friendly. But again, I think that's what they require to meet that standard is whether they have a policy, whether they have registers, whether they have access to salbutamol. So I think there is quite a bigger piece of work that needs to happen in terms of using turbohalers and dry powder inhalers. That is a big piece of work that needs to happen. And I think the difficulty for us when we prescribe MART, and the guidance for less than 12 is that if you're prescribing MART, you can still prescribe a salbutamol inhaler or salamol inhaler to be available for use if they were so unwell that they can't use a dry powder inhaler. So at the moment, our practice in the region is very much to say that we prescribe them MART, but we leave them access to a SABA, particularly in school, because the difficulties, there might be no one in school who's able to perhaps give the dry powder inhaler and monitor that correctly if the child is unwell. It is quite a difficult area because it gives a mixed message, and there are very many regions are very clear in their guidance that if you're prescribing MART, then you should not prescribe a SABA because otherwise it defeats the purpose. So again, there's quite a lot of work going on in that respect, but I would say there is a huge amount of education that needs to happen in school.
Thank you, Naomi. And then there's a question, patients are often given a SABA if attending with wheeze whilst awaiting respiratory assessment. Do you think that's appropriate?
I think it's if you're going to review them and just to try and see whether. So I've just seen someone in clinic this morning who was just given a SABA and then has been referred to secondary care. But if there's going to be a wait for them to be seen, then I would say that it would be best for you to also start an inhaled steroid, because what's likely to make the difference is the inhaled steroid. If you are in completely two minds that you're not quite sure whether this is asthma at all, then I guess there is some argument to say, we'll just give a salamol inhaler for a couple of weeks and see whether that makes a difference. But I think as long as you're reviewing the patient, I think if you're giving it and then leaving it for too long, and they clearly have symptoms at night, they clearly are having symptoms with exercise, then they should really be on an inhaled steroid.
Thank you, Naomi, and I can see Nicola wants to come in.
I was just saying that probably we would counter that slightly different in adults, in that we shouldn't be doing that with adults. If you're going to give somebody an inhaler now, first of all, there'd be quite a lot of people, you will have that opportunity to look back at their eosinophils. There's a lot of people will have had a historical full blood count done at some point. But if you are going to give them an inhaler, it should be ICS LABA as air therapy in adults. And what I would qualify with is more of an adoption of MART in children is going to make it much easier to progress into transitional care as well, because we're getting that messaging from day one and moving it through as well. So I think that's one of the things that we encounter, obviously, between transitions from adolescence into adult care, is that you then might be trying to switch them onto a different regime. So I think this will work out better with a more unified approach as well.
Yeah, absolutely. Yeah.
So I was going to say, yes, if they are 12 and over and they manage, if they manage a dry powder inhaler, then yes, you could try them with air. But if it is a younger child, then you are a bit stuck in terms of because it's not licensed for that age group, and also the only one that would be available would be a Symbicort 100/3, which is not what we tend to use on its own. So if you've got 12 and above, then that would be an option, provided they can use the dry powder inhaler, because even the older children, sometimes they don't necessarily manage the dry powder inhaler that well. So it would be important that they're able to manage it, and there should also be an element of choice. So some young people, unfortunately, even though they try the dry powder inhaler, do not like the taste and want to be on an MDI via spacer. So we sometimes, as you say, in that period of transition, try very much to move them into a dry powder inhaler. But we just need to be a little bit careful sometimes with children and young people.
Thank you. Claire?
Thank you. I just wanted to pick up on the MART plus SABA, or not to give SABA or not to give SABA. That's the question. I think in the adults we are articulating, Nicola, out with that it's not routine. We shouldn't routinely be prescribing SABA alongside a MART regime. And certainly that will be true for many of us in primary care, because remember, we have the largest cohort of asthma in primary care, and it's only a tiny cohort that come to our secondary care colleagues. So most patients should not need a SABA. It's really only the really severe patients who are under the care of Nicola who might need that consideration. And even then, I think, Nicola, you're moving away from that where you can as well, aren't you? In terms of the children, I think it is a real challenge to know when to give SABA and when not to give SABA, and we're going to try and articulate that, certainly in our regional guidance, to give you kind of clues, clinical clues of when to consider that, because again, the majority of patients in primary care where a MART regime is initiated in the older children, they shouldn't routinely be given SABA, but there are some cases that we see in primary care that really might have risk factors, i.e. allergies, anaphylaxis, evidence of severe exacerbations or hospital admissions. It's quite reasonable clinically on an individual basis to kind of safety net that person, that child, and that's what I think we're going to try and articulate in the paediatric children and young people's guidance. So I hope that helps, because I know there's a lot of questions coming through about that, and certainly the asthma plans that you read, whether it's Beat Asthma or Asthma UK, they do talk about blue inhalers if they're available as part of the red zone of the plan. So I think it's really important to kind of have that consideration, but it's very difficult to apply a blanket form answer to this, in my opinion.
Yeah, absolutely. Yeah. So we've probably got time for 2 more quick questions. John, I just wonder if you could answer the question about online pharmacies. That's a really good question, Rachel. Patients ordering stuff online.
It is absolutely a really good question, and it has been a frequent topic of conversation since November, when the new NICE guidelines came out. The answer to that really is I don't think we can actually stop people trying to order it. I think what we need to try is to have a look at those online pharmacies and try and make sure that their systems and processes are robust enough, and that the patients need to be honest, and that we've educated the patients to say, if you're on this MART, then you shouldn't need to have a SABA. And if you do, you need to be coming back and telling us. If you're not coping with this, you need to be coming back and telling us. So I'm afraid there is, again, like lots of the things, there's no easy, straightforward answer to that. But I've got to say, I can't remember which pharmacy it is, and I don't know what I've been looking at on my phone, but my Facebook feeds, in the past month has been full by one particular pharmacy with blue inhalers, and I'm thinking this is absolutely ridiculous. It just is not in line with national guidance.
No.
So I think we just need to be aware and maybe sort of try and get the patient
Yeah.
to be a bit more honest. I think is the answer to that.
I think the teaching, education, training of information for patients is really important there. Time for one more dead quick question. For over 12s, I think this is for Neil Money. Can we use the adult formulary off licence, or should we stick to Symbicort? What are your thoughts, Neil?
So I think so for the over 12, do you mean in terms of MART, or do you mean as air?
It's not specified. Andrew, are you still on the call? The question just says, can we use the adult formulary off licence? I don't know. Or there or both.
Yeah, because over 12, it is MART is licensed, so it wouldn't be off license. So, but it would, yeah, we would use Symbicort mainly. You can also, a lot of people will also use a Duoresp, which is licensed as a maintenance treatment, but not really as MART at the moment. But again, it will be used sometimes as MART. So we do see more use of off license over 12, but I would say, you know, we would try to use either Symbicort or Duoresp, but Symbicort is the one that's licensed.
Fantastic. Thank you so much, Neil Money. So we're now at past. Thank you all so much for your engagement and attendance. I was really pleased to see the number of people that are here. The guidance will be going out through the NTAG website. You are all very, very welcome to comment. I can assure you that the development team will read every comment and you will get a reply to your comments. With some of them we will amend the guidelines, some of them will say thank you, we have considered this, but this is why. So you're very, very welcome to comment on that. Thank you so much for your time and attention, and I will take on board the comments. I haven't directly addressed them about pheno consumables and machines. We do know it's a problem and we are working really hard to try to address it. So thank you so much to our speakers, Nicola, Neil Money, Claire and John, and thank you all very, very much for your attendance. Bye-bye.
Thank you.
Thank you.